upon.
Good evening, there, doctor. Are you there?
Yes, I am.
Yes, sir. So, would you like to share your screen and check if everything's okay?
Yeah. Give me 1 second.
Sure.
You
Yes,
can
sir.
see that well?
Yes, sir. Yes, sir. It's working fine, sir.
I have a video recording too. Do you want to do online or video recording?
I guess we can ask other doctors because this is working fine too. So, if you are comfortable
How many
with
people registered for the talk?
just a second, sir. I will check and let you know. Doctor, are you there? Good evening, doctor. Are you there?
Yes, I am. Yeah.
Sir, can you go ahead and share your screen?
Okay, just give me a minute. Yeah.
Sure.
Can you see the screen?
It's coming, sir.
Is it okay?
Yes. Yes, sir. It's perfect. Can you make it full screen?
Sure. Is it okay?
Yes, sir. Perfect.
Okay.
Can you move the slides as well? Like just 2, 3. It's fine. Yes, sir. Yes, sir. That's fine. Thank you so much.
Okay. Can I stop sharing?
Sure, sir. Sure. Thank you.
Hello, good evening, sir. So yeah, I think.
Hello. Hello, everybody. You can all hear me? Can you all hear me?
Yes, yes, great.
Okay. Hi, Dr. Bagga. How are you, Dr. Srivastava?
Very fine. Yeah.
It's crazy in Cleveland. We have National Guards coming to our clinic. It's been a disaster.
Are the patients sick as well, or they're not that sick?
Oh my God, they're like all. We have 90% now with Omicron and 80% unvaccinated, 31 to 55. And this is adult, not peds. And on
And
my
what's the
service, I have
severity?
55.
What's the severity of illness? Are they sick? Are
Very
they
bad.
sick? Yeah,
Very bad.
they're bad. Okay, okay.
ECMO, CRRT. Auxeris is doing a great job. It's a very good filter. So we'll see. I recorded the lecture too in the setting, but I have some time. So
Okay, so you came home, or you came home to?
yeah, I was on call in the night. Then I'll go back again.
Okay.
Why did we pick up Christmas Eve day to do this?
I think perhaps for days fixed over, and Christmas Eve is not a big deal here. You can imagine. Unlike where you are, yeah, yeah. But you're right. I once had ये जो Vellore की जो meetings हुई हैं, they were on Diwali, and I just said no. I said मैं नहीं करूँगा.
Right.
And they said कि दिवाली पे है. I said, I'm sorry, but मैं क्यों करूँ दिवाली पे? So then they postponed. वो जो last year जो हुआ था, last year.
Right.
जो चेन्नई group जो कर रहा था meetings, they were doing a number of these webinars.
Right.
So Diwali evening of all things.
I hope we don't overlap each other's talk, but I have mainly like very laid down a basic talk.
So you'll be mainly talking about the management. So I won't be drilling into the management. So I'll be mainly talking about the epidemiology, the etiology. Maybe there will be a very minimal overlap. अगर होगा तो एक दो slides का तो उससे ज़्यादा नहीं होगा. But I'll avoid yeah. Because एक आधा I think outcome की slide है जो mechanisms के ऊपर है और yeah, but chiefly it's epidemiology and etiology.
Yeah. Actually, I can share the slide before we start, so I can show
कोई
you.
बात नहीं, अब रहने दीजिए, अब रहने दें, फिक्र नहीं करिए, ठीक है। अब
Yeah,
अगर कुछ होगा
that's
तो
fine.
अगर थोड़ा repetitious भी हो जाएगा तो फर्क नहीं पड़ता, it doesn't matter.
Right.
Even if
But
it's
we just want to finish it in time. I have to be out in an hour.
I have about 22 or 23 slides, that's all.
Right.
So I'll finish in 20 minutes.
And if I have to leave, then probably I'll leave some questions later on. And
हाँ, वो हो जाएगा, questions वगैरह handle. Is COVID likely to go up? Are you likely to see more cases, or do you think it's going to plateau soon? Okay, what are the forecasts?
we'll see peak again in January.
Because India में ख्याल है कि February में आएगा.
Yeah, you will get by March.
February, March, that's going to be the time it's again going to come back. Our vaccines are extremely limited. The vaccines that we have are not too many. The government is
Our
not.
problem is we have vaccine, but we have some of the people who live in their world. Our vaccination rate in Ohio is very bad. It's 48%.
Yeah, vaccination India में तो है, मतलब जहाँ हो रहा है, पर अभी मतलब पर booster नहीं लगेंगे अब. And many of us have been vaccinated in January, so it's all good. It's a year now.
Yeah,
so,
it's not gonna have any efficacy.
Yeah, and the government को policy ये है कि सबको पहले लगना चाहिए, उसके बाद booster देंगे, ठीक है जो.
But can you get a booster from anywhere else? Like
No, it's not allowed yet. So they're not allowed yet. So it's. But हुआ क्या है कि in practice, people who are working in corporate hospitals, they have been able to get, without getting it recorded, because the vial has more doses than written on it, So the Covishield, I think, probably has 10 doses, but they generally has about 11 or something, So you can get a dose extra or whatever. So that's what I've heard. I don't know, but we are not allowed to take. Yeah.
We have a manpower problem too, because CMS mandated for dialysis unit, if you're not vaccinated, you're not working. So all the techs are leaving. A lot of the research staff is quitting.
Yeah. It's going to be again tough, Yeah. The numbers are increasing. Even in India, the numbers are now going up gradually. But not
Right.
Yeah.
It's just very sad. This thing needs to, we have not been in India for 3.5 years. I've not visited my in-laws, my brothers. It's just bad.
अभी तो ये वाला साल तो चलेगा. It's going to go on for this year. I don't think it's going to. Yeah.
It's going to get more worse. It's just, I was talking to Dr. Yap. They have some committee, like national meeting they were doing in the morning for the crisis. And she was just worried about, they're seeing a lot of misc, which we are doing too. Okay. And she is talking about how to do the sterilization for the PD fluid and all. It just, I'm actually surprised how advanced Singapore is.
It is. Yeah.
It is very advanced.
Yeah.
See, I'm not very good in PD. I do in the adult work, I do most of the PD, and those are mostly run by our nurses. Like, we don't have to do much in adult. You go and see and you're out. In kids, we do, but not like how many I have. I think I only have in Akron children 4 or 5. That's it. Pediatric. Chemo 3. So it just. How was the Indian meeting feedback for the nephrology? It was a very good program by Girish.
Yeah, it was a strong program. I think it was and I think it's well done by him, and 3 days, day one was the workshops and the other two were, no, I think he did a great job,
I love the hypertension session. That was run very well.
But I think it's in Calcutta, but yeah. पर ये समझ नहीं आता कितने लोग सुन रहे होते हैं actively, because I know कि one is always able to show good numbers, on webinars.
Right.
But I don't know finally how many are listening. It's good, to have these things. They are much more convenient. You don't need to travel.
Yeah, in person is always better.
I think there has been a lot of ये webinars वगैरह बहुत ज़्यादा हो गए हैं.
Right.
So you never know कितने लोग सुन रहे हैं, कितने लोग ध्यान से सुन रहे हैं. You hardly ever know that. Yeah. So there were, I think, about 500 attendees for the ISP and Indian Society of, which is kind of, mind-boggling. 500 लोग कभी आते ही नहीं है.
Right.
और सारी virtual हैं, you never know कितने लोग, how many are really on.
Right.
The ACP and the Asian Congress, I think there were about 5,000 delegates.
Yeah,
Just like the ASC, you can just imagine. मतलब सारा ही है, it's kind of, this is all, these are just numbers to kind of 5,000 delegates to the ACPN. ACPN need to get 200 rupees stuff. Most of लोग committed नहीं है. Who will travel to attend a meeting.
Right.
Can you hear me? Dr. Rana, can you hear me?
Yes, Dr. Srivastava, how are you?
I'm very well. Can you hear me?
Yes, I can hear you very well.
Yeah, you will, sir.
Can you hear us? Dr. Srivastava, can you hear us?
Yes, I can hear you clearly. I'm using my laptop. The big one somehow is just not working so well. Is Dr. Tandon around anywhere? Dr. Tandon?
Dr. Mehta is connecting with, I think, yeah. Good evening, ma'am.
Good evening, Dr. Mehta.
Yeah.
How are you?
Yes, I'm fine. How are you?
Good to see you. Good to see you. Good to see you.
Yeah, but I'm not very savvy like you on these gadgets. So
None of us are, ma'am. We're all the same.
yeah. But you must be doing it all by yourself. I got some helpers.
Dr. Srivastava, you logged in with two, I think from your cell phone and from your laptop.
Sir कह रहे थे कि हाँ उनका computer नहीं चल रहा है. He was saying कि the audio was not coming through the computer.
Is this working? Dr. Bhagwat, can you hear me here? No.
Yes.
Yes, we can hear you, sir. Yeah. Maybe you can put your laptop.
So on the desktop, can you hear now?
Yes, sir. Yes, we can hear you.
Or it's from the laptop then?
How are you, Dr. Mehta? How are you doing?
I'm fine, as fine as I can be at my age. But yeah, I enjoy meeting you. Yeah. So when did you arrive?
Well, I'm calling from Cleveland, so I'm in US right now.
Okay, all right. And yeah, I think I met you once only. You had come to Lilavati Hospital.
Yes,
Dr.
that was
Umar.
one time, long time back.
Not bad. My memory is not bad, but that was
No,
long.
you are great. You know, my Mausis are all in Bombay.
Ah, okay.
My both Mausis, my all relatives actually, they're
They're
all in the film industry. So that's why Dr. Umar Ali knows me well.
Why do you go to Delhi all the time? You should come and meet.
I will. My both Mausis are in Bombay actually. my Mausi's son, he's now in the censor board, Ashok Pandit.
Okay.
And
Okay.
Dr. Uma Ali is very good friend with them. And then there is a singer who came actually to do perform in Cleveland too, Kailash Kher. He's my Mausi's daughter's son-in-law.
Well, very well known, yeah.
Yeah, yeah.
Yeah, Kailash, as well as Dr. Pandit, Mr. Pandit, he's also well known.
Very, no? Pandit. And doctor in Detroit, a friend of mine.
What's the name?
He's the pediatric nephrologist. I forget the name now, you see. But he is also Kashmiri, and he came and stayed with me.
Sir, आपको ये बंद करना पड़ेगा, Dr. Srivastava. Sir, you have to probably close one connection. Either the computer or the laptop, sir.
Please mute or unmute. मत बताओ ना क्या करने का किधर.
Probably with my desktop.
So yeah, if you can put your computer off, sir.
Not as bad as in
વિડીયો હમણાં બંધ છે મેડમ વિડીયો હમણાં બંધ છે ચાલો કરવું હોય તો જ કરજો ના કરો તો વધારે સારું.
Am I audible?
Yes,
Yeah.
yes, you are, ma'am.
you are.
Doctors, it's almost 9:10, so we can start the meeting.
Want me to start? I don't see Dr. Tandon here.
મેડમ ટેન્શન ના લે.
Can I start?
Patient ને કઈ નહીં થાય.
તમે છો મેડમ તો
હું મરી જતી.
ચાલશે.
Just look at the thing.
Are we going to start? Dr. Baga, when are we going to start?
Yeah, I think sir शुरू कर रहे हैं sir.
We are the already.
Oh, she wants me to start. Huh?
I'm not sure.
Hello.
Yes, ma'am. Yeah.
Can we start, Dr. Srivastava?
Yes, I think I'll be starting now. Otherwise, there's a problem.
Yeah,
here.
because already 15 minutes are
So
gone.
I'm supposed to be starting it. So a very good evening, good morning, depending where you are. I am Dr. R.N. Srivastava, consultant pediatric nephrologist at the Apollo Indraprastha Hospital. We have a very important meeting here to discuss the problems of AKI, acute kidney injury in children. We have two eminent speakers, Dr. Rupesh Rana and Dr. Arvind Bagga from USA and New Delhi to make their presentations. We have a very renowned chairperson, Dr. Kumud Mehta from Bombay, and extend a very hearty welcome to both of them, all of them. I welcome the participants who have taken time off from the Christmas Eve to be with us. I hope this will be a useful session. The questions can be put in the chat box and they will be addressed after the presentation of both speakers. The acute kidney injury, a few words about that. It's a very common condition and requiring a very expert management. Some time back, AKI, acute kidney injury of renal failure, was quite common, and due to conditions like gastroenteritis and so many preventable conditions, many of these are still with us, such as drugs and toxins, snake bite in rural situations, villages. But in the hospital, we see acute kidney injury in a variety of settings. Multi-organ failures, complex surgeries, transplantation, so on. A lot of insight has been gained in the past few years toward understanding the mechanism, the pathophysiology and the management. There was a time when the treatment options were very limited. Now we have a variety of dialysis options, and the application of these in the management has been life-saving. The early detection, appropriate management, prevention of progression is important. Our chairperson, Dr. Kumud Mehta, is a senior consultant working at the Jaslok Hospital and Wadia Hospital in Mumbai. She is one of the pioneer persons to promoting the pediatric nephrology in India and our countries, the regional countries here. She has promoted the delivery of specialist care to children with renal diseases. She has mentored a large number of young pediatricians. Dr. Mehta has been closely associated with the Indian Society of Nephrology. She was elected as its president and honored with their Lifetime Achievement Award. She has a number of awards and orations, so I will be listing them here. She is a fellow of the Indian Academy of Pediatrics. She has given a large number of orations and talks and CMEs, numerous conferences in the country and outside. I think Dr. Mehta to kindly introduce the speaker, start the session. Dr. Mehta, please take over.
Hello. Hello, I'm Dr. Kumud Mehta. I'm from Mumbai, and currently I'm working at Jaslok Hospital, Mumbai. Along with the adult nephrologist, I've started the transplant program in children there. But I started with Dr. Srivastava and Dr. Namalwar from Madras, and three of us, like three musketeers, were for a long time Indian Pediatric Nephrology Group. It was not an association. But now we have almost 500, and it is so heartening to see all the youngsters wanting to do nephrology. Those days, neonatology, cardiology, these were very attractive because they were glamorous. And nephrology, the nephrotic syndrome patients used to stand with a tube of urine in the hand, waiting for 2 hours just to get proteinuria, which was done by the most crude method of heat method. But we have progressed a lot from there. And I'm proud to say that we are also almost one of the, not a developing country anymore as far as medicine is concerned. We are well developed in, especially nephrology. With these words, without, as it is, we have lost some time, I would like to introduce the first speaker. Dr. Arvind Bagga, I know maybe for last 30 years. He is one of the finest of the brains in pediatric nephrology. I would put it down. Very, very humble, very low key, and works very hard. He was groomed by Dr. Srivastava, and not only that, but he continued in the same spirit, but collected a whole lot of youngsters around him to carry out the research. And researched in AIMS, is one of the, sort of things which I always envy, because we don't have such luxury in Mumbai. And they're far ahead of us, and we always look to them to get their knowledge. And Dr. Bagga is the one who has spearheaded his work on nephrotic syndrome, long-term steroid therapy, steroid sensitive and immunosuppressive. Recent ones are calcineurin inhibitor and rituximab are well known. And actually IPNA, that is the International Pediatric Nephrology Association, takes cognizance of this, and he's always invited to find out the guidelines for the developing countries. And I salute to him. And I think I have to say a lot, but in short, what I would say is that not only he's interested in nephrotic syndrome, but his interest goes beyond that. And acute kidney injury is one of his, I think, specialties in which he has worked. And more so hemolytic uremic syndrome. He has contributed a lot to the complement levels in the atypical HUS, and he always looked up to him and sent our samples right from Mumbai to AIMS to find out whether this complement, what are the complement problems. And to our great surprise, we differed from him quite some time. We said we have different kind of clinical material, that is antibodies against H. Initially, I don't think he agreed, but then he found, yes, there is an entity. And then we said, we want to treat such cases with immunosuppression, and he agreed. I mean, that kind of exchange of ideas and respecting each other is, you may not find at many places, but that is what Dr. Bagga is. He has served as editor of Indian Pediatrics and Pediatric Research and is on the editorial board of Pediatric Nephrology. He's a prolific writer also, and he is very good at RCTs, and that's why he's in the Cochrane, sort of reports. Always his name is mentioned on the long-term outcomes of the different kind of modalities of treatment. And he also is on the board of Pediatric Nephrology, World Journal of Pediatrics and Current Pediatrics. And he's a member of KDIGO, again an international group on thrombotic microangiopathy and management of glomerulonephritis. His recent interest also is research in the inherited disease of kidney. And he has started, I think recently, screening for the cystinosis, which is a common condition in India, and we will get the benefit of their research also. Now, I've said a lot about him, but today's talk of his is on AKI. And as I mentioned earlier, he's going to touch on the two aspects, the AKI definition, mechanism and etiology of acute kidney injury. And with these words, I give you Professor Arvind Bagga. Yes, Dr. Arvind, go ahead with your talk.
Thank you, ma'am. Thank you for your extremely kind words. I'm humbled by your kind words. And thank you very much for your comments. We have always looked upon you for advice on virtually everything that concerns pediatric nephrology. And it's been a pleasure to kind of work alongside you and under your guidance. Thank you once again, ma'am, for this introduction. So I'll talk to you about acute kidney injury and some issues regarding its definition and something on the etiology. Why acute kidney injury has come to the fore has chiefly been because we know that in the last few years, there's been a lot of interest in trying to define acute kidney injury in a more standardized kind of fashion. And again, data emerging from multiple studies across the world showing that almost 20% or 25% of all patients who are admitted to hospitals, whether they are children or adults, would get acute kidney injury during their hospital stay. And this is a map across the world, that's showing the proportion of patients who get incident acute kidney injury after hospitalization. The second issue, which Dr. Raina would be covering, my colleague, who's really a pundit on acute kidney injury, is the issue of therapy. And the International Society of Nephrology, along with other organizations, would kind of, argue very strongly for availability of kidney replacement therapy. And therefore, this goal of 0 by 25, which is felt to be really a human rights case for nephrology. Just like you require antiretroviral therapy for AIDS, one should have facilities for dialysis, peritoneal and or hemo and other forms, that Dr. Raina will be discussing for acute kidney injury. So the way we define acute kidney injury, it is a sudden loss of kidney function that happens over few hours to days. The two major functional tests or major functional tools that we have, one is a serum creatinine and the other is urine output. We know that there are problems, in estimating creatinine, methods of estimation may not be standardized and so on. So they are listed here. The creatinine would vary with the age, with the muscle mass. Obviously, if there is fluid overload, as is shown here, the serum creatinine could be underestimated. And therefore, one may need to factor this overhydration component to be able to determine the real creatinine level and so on. But as of now, we still have serum creatinine as a very important marker or a very important functional marker of acute kidney injury. The other functional marker of acute kidney injury is urine output, which is thought to be the proverbial canary in a gold mine, and because very often this is not given enough attention, and the urine output may often decline much earlier than you really start seeing serum creatinine rise. And it does enable early diagnosis. So as of now, the two tools or the two functional tools we have really are shown here. And the audience would know, that maybe 2 decades, there has been a move towards standardizing the definition of acute kidney injury. We used to call it acute renal failure before. But since 2004, when the first rifle criteria came up, then we had the Akin criteria in 2007, and currently we are all using the KDIGO criteria since the last 10 years. And various definitions are there, but broadly speaking, they're all virtually talking about the same thing. So if you were to look at the KDIGO stage 1, the Akin and the rifle, they all refer to a 1.5 times increase of serum creatinine over the baseline that may happen over a period of 7 days, or even a rise of 0.3 milligram per deciliter of serum creatinine that may happen over 48 hours. And this is kind of uniform across various definitions. Stage 2 is defined as anything that if you show serum creatinine rise of 2 to 2.9 over the baseline happening over 7 days. And stage 3, which is the severest form of AKI, is a serum creatinine level of more than 3, or any level that's more than 4, or in newborns, a level of more than 2.5. And similarly, there are urine output criteria. So broadly speaking, the criteria are similar across various definitions. Currently, we would generally be tending to use the KDIGO criteria for virtually all our work. And as I said, there are some newborn specific definitions. Now, what's become evident over the last few years is that acute kidney injury, both in adults as well as in children, is a common problem. It's estimated that every year you've got about 14 million adults and children that are afflicted with acute kidney injury. Majority are in the developing world, and almost 10% of these patients would die of acute kidney injury or its associated complications. Overall, there is, with more and more sicker patients entering the ICUs, there has been a rising incidence of AKI, but pediatric AKI is clearly almost 1/10 of the adult proportion of acute kidney injury. Most patients have milder forms of the disease, but if you look at pediatric specific data, and this is a study from our center where we showed that almost 5% of our hospitalized patients who come to us with normal kidney function would get during hospital stay. And this figure is almost 30% for the ICUs. And in the ICU setting, many of these patients may show severe AKI, and a very high number would die. And we'll discuss this as we go along. The other thing that's become was that as you go from stage 1 to stage 3, there is a stepwise increase in mortality. And as is shown in the 2 boxes here, if you look at the pooled AKI associated mortality, clearly as you go up from stage 1 to stage 2 to stage 3, as is also shown in the odds ratio of mortality data that is seen here. So clearly, the staging of AKI does have a prognostic value in that sense. There was a recent paper about 2 years ago in Kidney International that talked about, whether AKI stage 1, which is a minor rise in creatinine, is different from AKI stage 1B, which is a rise of creatinine that happens over 7 days. And they showed that even within this subcategory, patients with stage 1A did better than those with stage 1B. So broadly speaking, this definition of trying to classify AKI into stage 1, 2, and 3 does have merit. And patients who have stage 2 or stage 3 are usually thought to have severe acute kidney injury. The other concept, that's is trying to get defined more and more is the concept of acute kidney disease, which is, really a progression of which is really defined by a loss of kidney function to below 60 mils per minute that happens in a period of less than 3 months, as opposed to CKD, where the cutoff is for duration is more than 3 months. Clearly, a proportion of patients with AKD would have a more severe form of the disease, a more faster form of the disease, which is defined as acute kidney injury. And then you have patients with no kidney disease. So this concept, one should understand, particularly the fellows and the younger colleagues who are listening, that AKI is a subset of AKD and which is really evolving more rapidly. AKD is perhaps also could be a much more slower evolution. But then again, the cutoff for duration when you would define AKD versus CKD would be a cutoff of about 3 months. this classification is known to almost all the entire audience that's listening. But essentially, you would define AKI into prerenal causes, which are shown here. The ones in black are much more commoner in children compared to the ones in red, which are more commoner perhaps in adults. A number of medications may also cause prerenal acute renal failure. If the prerenal failure is sustained for a long time, whether it's hypovolemic or hemorrhagic or septic, you may get acute tubular necrosis. Other causes of intrarenal causes or renal causes could be the syndromes of thrombotic microangiopathy or the various glomerular nephritides, whether it's immune complex or ANCA associated, and so on. And then you could also have post-renal causes, various obstructive uropathies, etc. And in children, these are the common entities are listed in this slide. Other thing that I kind of, was which I mentioned to you in the beginning was that as we are accruing more data on acute kidney injury, there is a feeling, if one does systematic reviews of various studies, that 1 in 5 adults, that's about 20%, which is shown in the data here, and almost 1/3 of all children who come to the hospital and get admitted with varying degrees of illnesses not come with AKI at onset, but they get AKI during hospital stay due to multiple causes. And this figure is kind of shown, and the first one that's shown on the left is a review in C. Jason published about 10 years ago. Almost 49 million patients, showing that the incidence of acute kidney injury, incidence means something that's happening in the hospital, is almost 22% overall and almost 34% in children. And obviously the ones who get AKI are at a higher risk of mortality. Again, a subsequent systematic review on almost 77 million patients from all that looked at 10-year data showed that incident AKI would be happening in about 20%, as is seen in this figure here. Variable proportions, across the world. About 11% of the patients who get AKI would require dialysis, and the ones who require dialysis, a very high proportion would finally end up dying. This is data from children. About a few years back, there was a global snapshot study in which data was collected for 10 weeks during 2014 across the world in pediatric centers, and here there were almost 92 centers contributed a very large number of patients in this global snapshot study. And there was data from across the entire world that was presented here. So of the 354 patients that were presented that were published, if you look at data from the low and low middle income countries where India would fall, there was a clearly higher mortality in this group, number one. And number two, that patients who were being seen in this group of patients, they had an equal number of community acquired as well as hospital acquired AKI, compared to high income countries and the upper middle income countries where there was much more hospital acquired. So these were, patients who were post-surgery, post-op, post-cardiac surgery, etc. in ICUs, children who were there, compared to, patients who are coming in lower and lower middle income countries with acute gastroenteritis, malaria, and so on. So in our countries, almost half the AKI that we see in our hospitals is community associated. It's often stage 3, and clearly there is a higher mortality. This is the kind of breakdown, of the etiology of AKI has happened at our center over the last few decades. When Dr. Srivastava was working, this is early 70s, diarrhea and infections really accounted for the majority, and there was a large amount of post-streptococcal GN. This has declined, and there was a window in between wherein we had a lot of Shigella-associated HUS, which again has kind of declined gradually, and now we see the common causes of AKI currently would chiefly comprise of infections, sepsis, and so on happening in the intensive care units, hemolytic uremic syndrome, and some other rare causes. There was an important paper, that was published in the New England Journal of Medicine almost 7 years ago, or 5 years ago, from 32 pediatric intensive care units from across the world, involving almost 5,000 patients. And what this data showed was that in pediatric intensive care units, almost a third of all patients And stage 2, stage 3 AKI was seen in almost 10%. And the presence of acute kidney injury, the adjusted odds ratio for death. So this is kind of, kind of an independent variable, but the presence of AKI did lead to almost 2 times higher risk of death compared to the ones who did not have AKI. And even within this population of patients, clearly, if you had stage 1 versus stage 2 versus stage 3, the stage 3 did the worst. So even in children, there is enough data on a stepwise increase in mortality, as was shown in this AWARE trial, AWARE observational study. And then there is data from the AWAKEN study, in which even Indian centers were involved. Siddharth Sethi and Dr. Professor Raina published in the Lancet again about 5 years ago, involving 24 NICUs across the world, critically sick newborns, again showing that almost 30% newborns did have acute kidney injury. And clearly the presence of acute kidney injury in newborns led to a higher mortality. So overall figure, that you seem to be seeing is that almost 30% of children who come to a hospital and who are sick would end up getting acute kidney injury and its associated complications. Now, what about COVID? We have all gone through this epidemic in the last 2 years, and there are now systematic reviews of both adult as well as pediatric data that's shown here. And I would overall summarize by saying, that almost 25 to 30% patients who are hospitalized with COVID would end up showing acute kidney injury of varying grades. The data from China has been a bit lower, as is seen in the first box on the top. But overall, if you look at data from the developed world, it's about 30% would show evidence of acute kidney injury, more often stage 1, but at times, even stage 3. A fair proportion of these patients would require kidney replacement therapy. And this is a meta-analysis from Dr. Raina's unit, wherein they saw 24 studies, almost 1,500 patients, showing an incidence of AKI in 30% children who got hospitalized with COVID and requiring kidney replacement therapy in a smaller proportion. And even in MISC, that we'll perhaps be discussing, the proportion of patients who show AKI is about 12%. So clearly, COVID patients with COVID who are getting hospitalized and who are critically sick would tend to show higher levels of acute kidney injury, as well as a higher requirement for dialytics support and so on. I'll just like to highlight 3 other facets, of AKI that adult colleagues with COVID. So just like, the HIV-associated collapsing glomerulopathy, there is perhaps a COVID-associated collapsing glomerulopathy as well. The other is the association of COVID with ANCA-associated vasculitis. And there are multiple reports. And more recently, we have seen patients who have got anti-factor H antibody-associated HUS that was perhaps triggered by COVID. This is in the process of publication in pediatric nephrology. So some of this data is ours, some of this is really published elsewhere. So clearly a number of syndromes that are linked to acute kidney injury might follow severe COVID infection. In interest of time, I'll perhaps skip, I won't go into details on this slide, but contrast nephropathy, while being an important cause of acute kidney injury in adults, there is emerging data, and as is shown in this large Mayo cohort of almost 2,000 patients, suggesting that contrast nephropathy may not be a big deal in children. Just about 3% of their patients, who were prospectively following contrast studies did show COVID on follow-up, and even these patients did show recovery. So clearly, contrast nephropathy may not be a very important cause of acute kidney injury in hospitalized patients. I'm not going to go into details of how you prevent this. Maybe Dr. Raina would cover this, or maybe we can take this during the question answer session. So if you look at the overall distribution of how AKI develops, and this has been the central dogma, that in the developed countries, AKI chiefly happens in intensive care units. Older patients who are much more sicker with multi-organ failure, having sepsis, and clearly with a high mortality. Whereas in the developing world, as I said, there's been a lot of AKI in the community, often affecting children. often there being single diseases like gastroenteritis, malaria, and so on. HUS, Dr. Srivastava spoke about snake bite and whatever, so these could all be, single discrete diseases. Overall, however, the scenario even in the developing world is changing. And as Dr. Mehta did mention, that India, is kind of is in transition. So we are seeing really both sorts of patients, both in intensive care units as well as in the community. So really an amalgam of what the problems that you're seeing in the developing and the developed world. I'll very briefly talk to you about, the clinical features of acute kidney injury, and you are aware about the clinical, so I won't really highlight them very much, but it's often thought, that the kidney is a victim of multiple insults that is happening. But there is more and more data that's accruing, that suggests that once you do get kidney injury, and once you get fluid retention, once you get release of cell debris through necrosis and so on, and disturbed homeostasis, one does end up getting secondary involvement of the brain, the heart, and so on. And this effect on systemic consequences of acute kidney injury are being increasingly recognized. And clearly, you can have a look at the current reference. This is a recent review article in Nature Reviews, as well as in critical care clinics, wherein one does seem to understand that once you get AKI, the other organs get affected secondary to the AKI. So it often, it's often the culprit of a lot of things that are happening downstream. I won't dwell too much here, but this is again the standard way by which you would be evaluating patients. So these things I'm sure are known to all, doing renal function tests, blood gases, a urine exam, and other things, for complications of acute kidney injury. In addition, one would do specific tests to figure out the underlying etiology that are listed here, depending on the underlying etiology that you're suspecting, and so on. A kidney is required rarely in acute kidney injury, but at times, one does require in context of a systemic disorder, or, if the AKI is not improving or you're suspecting cortical necrosis. But I would imagine that a kidney biopsy in normal course for AKI would be in a much smaller proportion. Now, can we predict the occurrence of severe acute kidney injury? I hope I don't overlap too much with what Rupesh is going to speak, but I'll not take too much time on this. So since the last few years, there has been interest in trying to, can we really predict the occurrence of AKI, severe AKI? And severe AKI here being defined as stage 2 or 3. The first test that's gained importance, or the first tool that's gained, which is really a product of the risk level in which the patient is being managed. So whether it is admitted to the ICU, or he's a transplant recipient, or he's on ventilation or inotrope agents, multiplied by the level of injury, as is defined by the creatinine clearance, the fluid overload, and so on. And if you get a renal angina index that's more than 8 to 12, there's a much higher risk of acute kidney injury being severe. And the other test, that's often discussed is the furosemide stress test, which is thought to be a treadmill test for the kidney, in which, one would kind of give, and this has been done even before, one is aware, that we were using furosemide in our casualties much before this test really has become a standardized test. But now it's known, that if you were to give furosemide at a dose of 1 to 1.5 milligram per kg and observe the urine output over the next 2 hours, if the urine output does not increase above 100 mils per hour, it predicts stage 2, 3 AKI within the next 7 to 14 days. And the furosemide stress test is clearly a sensitive test to be able to pick up and predict the occurrence of severe acute kidney injury on follow-up. So there is a combination. So one could combine the renal angina index with the furosemide stress test, and both these tests could give you a more better prediction of the occurrence of severe AKI. I'll probably skip this, but just to say that biomarkers have been in vogue for a very long time, almost 2 decades now. Overall, I don't think they have changed the way we have been practicing medicine, at least in India. Maybe Rupesh can add, how they've really affected the management of AKI in a more developed kind of setting. But the role has been limited, and this was a recent, clinical practice guideline by the Japanese Society of Nephrology, wherein they do end up saying, that the role of biomarkers for predicting the need for renal replacement therapy is clearly limited. So the role of biomarkers is currently limited in children. I'll skip this, because I think Rupesh should be covering this. Mortality.
Hello, I just want to know what is the problem? Because we have only now 15 to 20 minutes left. Dr. Baga, it's somebody.
Actually, can you please ask Dr. Baga that he's not in the Zoom, and if he can reconnect, please?
Should I introduce you, Dr.
Can we have Dr. Rupesh Raina's talk in between if he is available?
Yes, I am. I can start if you guys are ready.
And then Dr. Baga can take over in question and answer. Otherwise, Dr. Raina won't have any time to talk.
Yeah.
If I'm permitted. Is it
Yeah, yeah.
okay, Dr. Raina? And is it okay with Dr. Baga also?
Yes.
Yeah.
Let me start it.
Yeah. So now let me introduce the second speaker, Dr. Rupesh Raina. And he is remarkable. He has got a wide spectrum of his patients, adults and pediatrics, as well as I think many of the kidney diseases, he is involved in care of them. And one of them is hypertension. And of course, recently, what I learned from his biodata, that he is also doing transplant, obviously, not only the kidney transplants, but bone marrow transplants. And his patients are adolescents, also going into the adulthood. And that's why he has transitional care, which is of a great interest to me because I do preemptive transplant with the organ donors being given by one of the relatives. And I also do this transitional care. Anyway, that's besides the point. Time is short, and that's why I can't read all his achievements, but enough to say that his main work is in Cleveland, Ohio, and his NeoMed services. He has been, appointed with various positions, which is in Case Western Reserve University, a well-known university. I visited it once. And he's a fellow of National Kidney Foundation and American Society of Nephrology. And now he's not only interested in clinical nephrology, but he also does non-invasive biomarkers. One of them is urine endothelin 1, and to predict the ADPK disease progression is one of his interests, and also he's involved in that. With these words, I request Dr. Raina to talk on his subject, which is a management outcome and prognosis of acute kidney injury in children and adults as well, because I think we have some physicians also in the audience and they would appreciate his comments on them. Thank you,
Thank you,
Dr.
Dr.
Anna. You can go.
Thanks a lot, Dr. Mehta. First of all, I want to thank Dr. Srivastava for giving me an opportunity to talk in this forum, and my special thanks to Dr. A.K. Tandon. He has been there.
So he can go through.
Thanks to Dr. A.K. Tandon for giving me an opportunity
Thank you so much.
Thanks to Dr. A.K. Tandon too for giving me an opportunity. I'm going to talk about management, outcome, and prognosis of acute kidney injury. Before I go and start, can I ask everybody to be on mute so I can move forward? If Dr. Mehta says yes, then I'll move forward.
Yeah.
I think Dr. Baga has kind of covered a lot of topics in AKI. And sorry, today is not a good day for us because in Cleveland Clinic, we have the National Guard moving to help us because we are loaded with the Omicron in Ohio. Almost 80% of the populations are Omicron, and we are seeing the peak again. And it's going to get worse by the end of the Christmas, and probably it will be going to be more problematic down the road. And I only wish that you will all not get into that spectrum of the epidemic. And it's really it's a challenge for us. So let me start with some of the points in the lectures, what Dr. Baga kind of dropped, and I'm taking it from there, and he's happy to chime in during my presentation. The AKI is really changed in the paradigm. Like initially, there was no clear definitions for the AKI. It was not very recognized. Now we have some potential definitions, standard diagnostic criteria over and above. The AKI severity grades represent patient groups with increasing severity of illness, as illustrated by increasing proportion of patients treated with RRT and increasing mortality. Now, there is a cost-effective analysis and has various cost-effective models have been developed, which shows that the AKI is very much a burden, at least in the adult and pediatric world. This is a paper that we published, actually, what are the advances in the new last decade. And you can see the timeline of a landmark studies at pediatric acute kidney injury moving or taking a pace, I would say in 2010, 11, and now in 2019 and 20. You have a couple of the societies and the guidelines which is coming along. One of them is PCRRT guidelines, which we are working with Dr. Baga and Siddharth Sethi in India. Siddharth is one of the integral part of the guidelines. We have pediatric aware study, which is going. And the most important thing, the achievement which I have seen in 18 to 19 is establishing neonatal AKI awakened group, which I'm one of the steering committee, and multiple paper came out. But this is how it shows that the growth is in the last 10 years, and multiple new devices have evolved, including the devices for the neonates like CARPEDIEM, NIDAS, and various definitions have been established to an extent that KDICO now has recognized that pediatric AKIs is a subset, and in the guidelines, we were given full liberty and the chances to talk about the AKI. Definition is still very arbitrary because you talk about the creatinine, you talk about the urine output. One thing I really, really want to emphasize, urine output is very important and a time sensitive, hourly sensitive, because you need to have osmol needs to be secreted in the urine. And any definition you look, it is very, very pertinent and important, even including the modified rifle criteria for pediatric children's, which is also determined on the amount of the urine output and also the time sensitivity. And also anuria for more than 12 hours is bad. It's considered to be a high risk for AKI, ATN, and further deterioration in the health. Who suffers injury and who's at the higher risk? This is not hypoperfusion. There is a mounting evidence suggests that this is multifactorial, complexity of development, and the treatments are present. And you can see that AKI incidence increases significantly according to the sepsis severity. 4.2 for sepsis, 22.7 for severe sepsis, and if you're in a septic shock, 53%. What is the level of associated illness, cost, and outcome. Compared with non-septic AKI, septic AKI is associated with higher acuity of illness, and proportion of patients supported with RRT have increased for the last 10 years from 24 to 89% as they progress from sepsis to septic shock. Mortalities are higher in patients with AKI. If you talk about again stage 3, it's 64% compared to stage 1, which is 35%. Where is the injury occurring? And this is an operating hypothesis because it's a unique form of kidney injury. It is direct organ-specific mediated by the injury of sepsis syndrome. Inflammation plays a very, very critical role. And mitigation of this direct sepsis-mediated injury should attenuate the effect of AKI as measured by improvement in renal composite endpoint and mortality. And this is a nice diagram to show that there are so much of major apoptotic factors which are involved in the AKI ATN practice. And what happens is that it potentiates the oxidative pathway, which requires an activation of the plasma membrane fast receptor that causes a signal transduction via FADD, resulting in the activation of the caspase 8, which lead to the activation of caspase 3 and lead to apoptosis. Which is the best example? Better than this, you can see in the setting how it is mediated by the caspase and apoptotic fracture in the setting of renal replacement therapy in hematopoietic stem cell patient. And not only it is a multifactorial, what I will say, the chemokine burst, but it also entails fluid overload and other factors that can contribute to this this model of sepsis-associated AKI. How can diagnostic and therapeutic move forward towards improving the outcome? You need to have a risk assessment, and that is very, very important. And this is a paper which published by me and Siddharth in the pediatric research. And this is a nice flow of the diagram because you need to have an assessment of the risk factors. What are the risk factors can potentiate the AKI? What can you do, or what are the patients who are susceptible to the AKI? Then you have a damage. When you talk about damage, what are the factors you look into it? Fluid overload more than 10%, increase in serum creatinine, various P-referral KDIGO-ECHIN classification, which has been shown, including pre-ROC. Then you have a GFR. Now, in between damage and the GFR factor, you're looking for the biomarkers. Now, what are those biomarkers? In this paper, I'll highly suggest to all the postgraduates to read this, is that we have made a funnel diagrams, how these biomarkers are showing the efficacy in various kind of AKI. And when we found out that NGAL was very well representative in the setting of AKI and cardio bypass surgeries. IL-6, what a beautiful example you can see for chemokine burst in the setting of the COVID-19 chemokine burst. And IL-6 is most important marker now. KIM-1 is kind of evolving, and there are other factors for the biomarkers which is coming around. The problem is we get consulted between kidney failure and death, then I had no other options to except I use the RRT. And this is a beautiful slide to show whether you use P-rifle, KDIGO-ECHIN, the odd ratio in the stage 3 is 6 times, 5 times, 6 times of mortality, and which is such a serious consequences of AKI in pediatric setting. Golden hour. Trauma, you have golden hour. Stroke, you have 3 hours. Acute MI, you have 6 hours to give all the intervention. Now, sepsis-associated AKI, there is nothing that has been defined as a golden hour. Early shock is often hypodynamic. The effect of GGT are different depending on the severity of inflammation and shock. What do we do once energy is established? We don't have much golden hour to act. By the time you see creatine, the multiple damage has happened not only to the kidney, but other organ. It comes as a part and parcel of multi-organ dysfunction failure. Targeted molecular therapy and cell-based therapy. Now, AKI is now seen as a multifactorial process involving apoptotic, immune, and inflammatory process. And their novel prospective medical therapies are directed at these pathways have emerged and could be potential therapeutic value. We may be targeting the apoptotic pathway and caspase inhibitors and may suppress the inflammatory cascade, have shown some promising result in experimental model. Recent experimental data and evidence from a small pilot trials have shown a potential for enzyme alkaline phosphatase to improve SK, sepsis-associated AKI, by favorably modulating the immune response. Genetic polymorphism is growing in sepsis-associated AKI. You can see the TNF and IL-6. When it is present, it's 26% versus 6% at the incidence of AKI. When you have TNF alpha versus TNF alpha R, no associated with renal function or mortality. IL-10 is protective for sepsis, and an NADPH oxidase phosphorus catalase has highly significantly different high in the setting of septic AKI. Now, this genetic polymorphism, now we are dealing in the setting of the COVID-19 patient. If you see IL-6, IL-18, and IL-10, these are the factors we are trying to remove in the first 24 to 48 hours, which we published the PCRRT guidelines. And now, right now with the surge, I'm using an extracorporeal absorption therapy, which is Auxeris, and we use it for 24 to 48 hours because you don't want to remove the good chemokines or pro-inflammatory, but also there are anti-inflammatory chemokines that come in play after 48 hours. And that's a rationale. The extracorporeal absorption therapy should not be more than 24 to 48 hours. And this is what some of the new growth in the genetic polymorphism and sepsis-associated AKI. This is another one which shows that if you consider the combination of TN-alpha being high and IL-10 low, producer genotype combination was associated with 6-fold increase in risk of death compared to TNF-alpha low and IL-12 intermediate and high producing genotype combination. So it's very patient specific when you talk about AKI-ATM. This is another paper which has been shown how the normal epithelium damage to the total acute tubular necrosis and how you regenerate. There are a lot of things which are underdeveloped, and phenoldipan, which is more or less a vasodilator, and then you have an iron chelators, defripone, and then you have anti-inflammatory MSH analog, which can be used, but these trials have not shown very efficacious. This is what the golden period is between 8 hours, 6 to 8 hours from AKI prerenal stage going into complete damage, and then we lose this time frame, and then you have the complete tubular damage from phosphoprotein add to the tubular epithelium. There are some of the therapies which is apoptotic inhibitor, which is P53 siRNA, which is going in some of the trials. What we are doing in adult, what we are using is a stem cell, so we can help in the regeneration after the sloughing of the cells and luminal obstruction. Maybe that can potentiate the early recovery of ATM, but these are all in the trial, and some of them are animal model. Fluid overload is a disease, it is, and all of us should know how to calculate, because calculation is the most important part. It is itself is a disease etiology. It's itself is a diagnosis in various form. We have shown that even in the Awaken study, fluid balance on postnatal day 7 and negative fluid balance at postnatal day 7 were independently associated with mechanical ventilation. Now, this is very important. I really want to pay some attention to the precision of the fluid management in the continuous renal replacement therapy. The problem is this is patient, third is spacing, intravascularly volume depleted, nutritionally into catabolism, and that is what we are calculating as a machine balance. We are not calculating the correct body waste, body surface area for giving the replacement fluid. Are we managing, are we doing the precision of the fluid management in CRRT or any modality so that we can combat or at least can take over the fluid management or electrolyte homeostasis in the patient itself? It's a big challenge in the setting of AKI. When you talk about the fluid overload, 10%, 20%, and more than 20, the mortality is rising, 29, 43, 65. This is a paper, actually, we combined both renal angina index and fluid overload. And what we found out that day 3 AKI rates were higher in patients with RAI of 8 or more, and higher area under the curve had a better prediction rate on day 3 AKI less than 8 versus negative predictive value about 95% for day 3. So maybe it's a paradigm that we have to combine the fluid overload, renal angina index, all the biomarkers to prevent from the stage of renal failure to complete renal shutdown and eventually leading to mortality. Calculating renal angina index, I'm not going to go into detail. Dr. Bagga already kind of expressed very well in that setting. And again, this is some of the risk factors for renal angina index. My problem is if you go into the ER right now and say that you have a chest pain, you'll be admitted, you'll have a serial troponin going on, and then you'll go home by stress test. But there is nothing equivalent to chest pain for renal AKI. We don't know which patient is going to get AKI. Sometimes you get a consult where patient came in for a minor orthopedic surgery. He's already on metformin. They gave ketorolac. They continued the ACE inhibitor, and now you see sudden increase in the creatinine. So there's so many factors, but we do not have any what we call as the renal angina word, which is not correlating very well with the cardiac angina, because we do not know whether creatinine increase is what is needed. We don't know what are the criteria that we are using to predict AKI. We can only correlate with the mortality and morbidity. Is fluid accumulation should be an alarming factor for ICU? These are the point of discussion that will come into place very soon. And this is a paper, actually, we did a very nice PCRRT consensus guideline on AKI and BMT. It's got accepted yesterday. We have the panelists from all over the world. What a beautiful transition study of all these points that I'm enumerating into AKI and bone marrow transplant. You will soon get these guidelines out in pediatric nephrology. I'll highly encourage you to read. The area of AKI BMT is a good way of mitigating these challenges that we are seeing in sepsis-associated AKI. What you have to do, you have to look for high risk. Discontinue all nephrotic agent when possible, NINJA study. Ensure volume status and perfusion pressure. Consider functional hemodynamic monitoring. Monitor serum creatinine and urine output. Avoid hyperglycemia. Consider alternatives to radio contrast procedure. Non-invasive diagnostic workup. Consider invasive diagnostic workup. Check for change in drug dosing. And you move on to that. There is a new terminology coming in, which called what we call is acute kidney disease. When you have damaged kidney function or your GFR does not get better less than 3 months after the AKI. And this AKD subgroup is very important because these patients, if they get another bout of AKI, within 3 months, they're high risk of going into the CKD. So this AKD will be a very important area, sensitive area to look for any kind of follow-ups after the AKI. This is what the guideline says in KDIGO. Evaluate patients 3 months after the AKI for resolution, new onset or worsening of pre-existing CKD. If patient has CKD, manage them accordingly. If they do not have CKD, consider them to be at risk of CKD and care for them as detailed in KDIGO CKD guidelines. So these are the things that AKI follow-up are very, very important. And actually, they are in process in adult submitting a UO on grant about what we call as kidney protection after the AKI, and want to see how we are doing a follow-up. What are the cardiovascular changes that occurs? What are the inflammation, post-inflammatory changes? What is going on with the patient's cascade after the AKI recovery? And this is something we'll throw some light for in the follow-up of acute kidney disease. Causes of AKI, I'm not going to go into detail. Urine sediment is so important to look into the microscope. This is what you have a tool at the bedside. Look for the ATN, look for any kind of other urine sediments, which is important and can lead to the diagnosis of the AKI. And then you definitely look for various other serological markers. What index is better? FeNA and Furia. We have a nice systematic review that was published looking into the detail. But here I want to put in there that causes of falsely low FeNA in patients with intrinsic causal acute kidney injury. You should know the differential: cardiorenal, hepatorenal, CHF, renal artery stenosis, bilateral, acute glomerulonephritis, acute interstitial nephritis, in selected cases of acute tubular necrosis, except especially radiocontrast, rhabdomyolysis, myoglobinuria, non-allegoric acute tubular necrosis. These are the differentials for you to know the patients who have pre-renal state, but they are intrinsic. These are some of the sensitivity and specificity of fractional excretion of sodium and fractional excretion of urea, including the negative predictive value. In absence of hemorrhagic shock, we suggest using the isotonic crystalloid rather than the colloids, albumin, or starches as initial management for expansion of intravascular volume in patient at risk for AKI or with AKI is so important. This is some of the things that you have to pay attention to non-dialytic management of acute kidney injury. You have to look for various kind of nephrotoxic medication. Believe me, ninja studies have shown and proven that. You have to look for any kind of cardiovascular disorder. You have to look for the etiology of the AKI, maintain fluid balance, maintain the electrolyte homeostasis, maintaining blood pressure, maintaining the renal perfusion. These are very small, minor things, but can prevent further deterioration of the ATM or AKI going to ATM. This is an international consensus recommendation, survival sepsis campaign in 2012, 2017, and the ACCM and PL 2017, which I was involved for the management of sepsis, septic shock in children, advocates the use of aggressive fluid therapy, which is 10 to 20 ml per kilogram to be given over 5 to 10 minutes, up to 40 to 60 ml per kilogram or more over the first hour. But the jury is out because this is what the trials have shown. As you can see, this is a very important study, which is known as the trial for looking into the role of the fluid overload. Some of the important things were shown in this study is the FEAST trial is that risk of mortality at 48 hours was significantly higher in the FBD than no bolus, and there was no significant difference in mortality between albumin and saline. So now the spectrum is changing. Now we are using more ringalactic as a mode of initial resuscitation. Initially, we were using the normal saline, and albumin and saline is kind of pretty hard to tell. I think I use albumin more in children as compared to adults. It's hard to get to justify. But again, FPT with albumin or saline has increased absolute risk of death by 3.3%, with most death occurring within the first 24 hours and majority within 48 hours. Adenosine receptor antagonist. We suggest that a single dose of theophylline must be given in neonate with severe perinatal asphyxia who are at risk of developing AKI. If it appears that if there are benefit of using adenosine receptor antagonists to decrease tubular glomerular feedback, that mediated vasoconstriction and it increases the renal blood flow and GFR in AKI, they must be limited to a very specific population, which is asphyxiated newborn. And this is our study from Awaken study, which has shown that caffeine administration the first 7 days after the birth may be associated with less frequent acute kidney injury in preterm neonate. Further studies on dosage, timing of administration, and long-term outcome is needed. Vasopressin, relative depletion in septic shock versus increase in cardiogenic and hypovolemic shock. Definitely it causes mesenteric vasoconstriction, decreased cardiac output, significant urine output, and significant increase in serum creatinine, increased renal blood flow, and limited effect on the B2 receptors in sepsis. Again, hemodynamic monitoring is very, very important. We suggest using a protocol-based management of hemodynamic and oxygenation parameters to prevent development or worsening of AKI in high-risk perioperative setting. At least keep the mean arterial blood pressure more than 65, CVP between 8 to 12, improvement in blood lactate level, cardiovascular oxygen saturation 70%, urine output is so important and time sensitive. AKI guidelines, this is so close to my heart. We make nutritionally deprive these patients in the setting of AKI. We suggest achieving total energy intake of 20 to 30 kilocalories per kilogram per day in patient with any stage of AKI. We suggest avoid restriction of protein intake with the aim of preventing.
Excuse me, doctor.
Yes.
Sorry to interrupt. Just a reminder, we are 15 minutes past time.
So what do you want me to do? You want me to continue or not?
Yes, sir, you can continue. You can just like.
We would like you to use the 3 minutes for your talk. I will sacrifice my time for summing up.
Okay, thank you. So we suggest administering around 0.8 to 1 kilogram per day of protein in non-catabolic AKI patients with the needs of dialysis. This is a very important part of nutritional management on the critically ill child with acute kidney injury review and nutrition guidelines. We are working now with the European guidelines, and we will be soon coming out how to manage the AKI nutrition. And these are some of the guidelines, especially in the patients who are using the renal replacement therapy. You should be using 1 to 1.5. And if they are in a hypercatabolic state, please use 1.7 gram per kilogram per day for nutrition. Again, diuretics, Dr. Baga is kind of touched, but I'm not in a big favor of converting oligoanuric to anuric to oligoanuric after giving the Lasix. But yes, Lasix challenge is important. And there's no benefit using the Lasix, and there's more deleterious effect making oligoanuric or anuric to non-oliguric. This is International Pediatric Dialysis Modality Survey that we did. We found out that most of the people I don't use the term developing country. I like when Dr. Mehta said that India is very advanced in the medical world, and I agree with that. I did my training in India, and I'm very proud how medically we are developed. And I don't like the term developing versus non-developing. I'll say resourceful versus resource limited. And we are also resource limited in some part of our own country. 90% we use PD and primary modality people in the international survey. Now, this is some of the change in the paradigm in more resource full countries. People are using CRRT and hemo, resource limited more in PD. But you have to change the paradigm. It's renal support, because this approach is based on the utilization of RRT technique as an adjunct to enhance kidney function, modify fluid balance control. This is a nice layout for various kind of modality of treatment for RRT. And this is a paper I published. This was very close to my heart, is that this is not kidney replacement. You have to change the concept to use kidney support therapy, because that is what we need. Just not for life-threatening indications, solute removal, fluid removal, but we need to work for nutritional support, volume control, manipulation of cytokines, solute modulation, cancer chemotherapy, respiratory acidosis, fluid management. Now, the renal support is support other organ based on individual need. You need to have a target for overall support, and there are non-renal indications. These are the various kind of modality. For hemodialysis, you can use CRRT, SLED, hemodialysis, and PD. And we have a lot of paper and data coming from SLED, from Siddharth Sethi and Dr. Rajiv Sinha's work. And Rajiv must be attending, and he and Siddharth have a very good registry. SLED was actually first was decided and was invented in clinic by Dr. Pagadini. And now we are using a lot of SLED in CRRT patients as a step down, because we are resource limited with as far as the machine is concerned in the setting of COVID-19. And definitely PD is like preaching a choir in India about PD, you know more. CRRT is up and running too. And these are some of the new paper that we actually published in ACKDA, JKD about advances in kidney replacement therapy in infant. There are many machines now, Carpedium, Nidus, Aquadex, Prismaflex, HF20 we are using now. We have Aquadex in our center. And this is so important because this has taken care of some of the challenges, because we need to have inaccurate control of volume can lead to fluid and electrolyte imbalance. These are smaller circuit, less blood volume is used. We do not have any problem with large calibers catheter by the venous catheterization, hemodynamic instability from a large extracorporeal volume of adult system. These are the things that has evolved. I will highly suggest all of you to read this paper. It's been done by IAP, me, and Peter Norris and Siddharth, and we have really laid down the protocol and efficacy of these new modality of treatment for the neonate. Definitely, if you have increased intracranial pressure, DPI, or any trauma, CRRT is better. It causes less change in the hemodynamics. And again, hypotension and other parameters are growing, and we have a lot of PCRRT group, which is now PCRRT iconic, which will be launching more in January, will entails all these practice guidelines in the setting of AKI. To conclude, sepsis increases the mortality of AKI, AKI increases the mortality of sepsis. So it's balanced, but like both each other are balancing to lead to more mortality. And more than half of the children with septic AKI present with renal dysfunction at discharge, and 1/3 they develop abnormalities in long term. All of these patients are very, very important. Genetic risk factors may be involved in the individual susceptibility of the septic AKI. Fluid resuscitation, avoiding fluid overload, hydrocortisone, telepressin, Trotigon alpha, intensive insulin therapy may be useful in the management of septic AKI, but further studies need to be done. AKI biomarkers hold promises for early diagnosis of AKI development and intensity, but I don't know how it is important. I would like to conclude with one thing which I always say: whatever you have, act early. Grow out of the concept of using RRT for life-threatening. It is not renal replacement, it's a renal support. The paradigm has changed. The process of the multifactorial causes of AKI affecting the chemokine, caspase-systems, apoptosis. It is a syndrome. The earlier you act, the better it is. Please be very careful with the nutritions. These patients, we make them really nutritionally deprived in the setting of KRT. With that, I want to end my talk. And again, risk stratification based on demographic alone may not sufficiently enrich the population, optimizing the AKI. Renal angina concept that combined risk stratification, clinical side may serve well to optimize the biomarker availability. With that, I want to thank you all for giving me an opportunity to talk. I think Dr. Bagga is here. He may have just missed a couple of his end slide, or if he wants to add to conclude, I'll be happy to have Dr. Bagga take over.
It's okay, Rupesh. I think you've covered. I think I'm fine. Probably the last few slides didn't go through, but it's fine. It's okay. Thank you.
You want to say some concluding remark, Dr. Bagga?
No, I think it's okay. We'll probably take questions but I think it was thank you for a very nice talk, Rupesh. Thank you.
Yeah, thank you, Dr. Bagga.
Very nice overview.
I request Dr. Arun Srivastava to conclude and give his remarks at the end of the session.
Both very enlightening talks, really remarkable. I think the recording will be available, and those who want to listen to it probably will have a good chance. There's so much to learn now. There's so much progress has been made that really, I mean, some of us who have been, managing these patients many years ago, there's so much new has come up, and this has to be translated into the management and maybe smaller hospitals. And of course, you need the techniques of dialysis and support therapy and all that. I thank Dr. Rana for being with us on Christmas Eve. It's really very, very good of you. So have a good Christmas, and so we'll meet you next year.
Yes, thank you, Dr. Srivastava, and thank you, Dr. Mehta. It was so nice to see both of you. You just get so emotional seeing the people from our own country where you are born. And I was telling Dr. Bagga before our meeting that we've not been to India for 2.5 years. And this is just what we call as electronic world, but it's very nice to see you and Dr. Mehta, and I've heard so many things about you. And nice to see Dr. Bagga too, because it's been a long time that we met personally, and this is a nice way to collaborate and more pleads for the AKI. And this is really, as you said, Dr. Srivastava, it's a growing discipline, and I have learned a lot. New things are coming in, and new things are growing along. With that, I would really want to thank you all, and thank you, Dr. Srivastava, for the invitation. I was very honored, and I told my institute I cannot say no to Dr. Srivastava. I have to go, and despite that, all the pandemic and chaos going on, I was here. I'm very happy. And also, I want to thank Dr. Tandon. He has been very, very generous and nice to me. And I was very, very happy to see how I feel welcome. And with that, I wish you all a very, very happy holidays, Merry Christmas, Happy New Year. And the one thing I really want to wish you from my core of the heart, please do not see the pandemic again, despite that we are dealing right now.
Thank you, Rupesh. Thank you.
Dr. Mehta.
Yeah, I'll be failing in my duty if I don't thank Dr. Srivastava. He's the last but not the least, and he's the one who pushed me into it. because I'm at an age I like to be a student rather than sitting on the chairperson. And also Dr. Tandon, whom I didn't know, but he was so sort of nice inviting me. And of course, all of you have a best time in Mumbai. Mumbai is much better than any place in the world. And let me assure you, it's quite safe also. Thank you very much. And I think I've concluded this session because our lady is looking at me quite angrily now. Okay, bye.
Okay. Thank you, ma'am. Thank you.
All the
Bye-bye.
best. Thank you. All the best.
Can we leave?
Yeah, I think so. They are
Because
not-
everybody's leaving now.
Huh?
Everybody's leaving, so we can also.
Yeah,